Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, thanks to Shrisha Danredi for doing another talk for us. Shrisha was just here 2 weeks ago talking about the new vaccine guidelines, and today we'll sort of transition to travel vaccines. I think you all know Shrisha pretty well, so I'll just turn it over to her.
Yeah, great. Hopefully you're not getting sick of me. This isn't just focusing on vaccines, though. This is just a general overview of what you should be considering when you have someone with HIV who's going on a trip or who may be returning from a trip somewhere. And I'm talking about abroad, obviously, not to Pocatello. Overview, pre-travel visit, what we want to cover in terms of vaccines and other prophylaxis that you should be considering. What they should be counseled about in terms of safety and precautions that they should take while they're away, and then the post-travel visit for people who come back and may have an acute issue related to their travel. So obviously I won't be able to go into a lot of detail in 15 minutes about all of this stuff, but I wanted to hit some highlights. So in terms of a case, a 49-year-old Eritrean woman with stage 3 HIV, but her last CD4 count is 450, and her viral load has been undetectable on atazanavir, ritonavir, and tenofovir emtricitabine. She presents, fortunately, 2 months prior to travel. We don't always have that luxury. People say that they're going to be leaving next week, and I know Jennifer Mignani is here and has to deal with the repercussions of trying to get their antiretroviral supply for the entire time they're away. She immigrated to the U.S. About 10 years ago and is otherwise doing pretty well. So what issues should you address at this pre-travel visit? Well, you obviously want to know your geography. Where is this person actually returning to? And specifically, what parts of that country are they returning to? Are they going to be in rural areas? Are they going to be in urban areas? And you really want to be pretty explicit, because when you actually look up where they're going on the CDC website to look for precautions that they should take or vaccines, you need to know that information. So getting a detailed history about where they're going and what they might be doing while they're there. Are they going to just go to an urban setting and visit family? Or are they going to a rural setting where they're going to have a lot of animal exposure, water exposure, farm exposure? So you want to ask specific details about what they're doing while they're abroad. Getting a vaccine history, which hopefully if they're in your care, you already know a lot of their vaccine history, but sometimes that's actually difficult for our patients who come from abroad and didn't necessarily receive a lot of their childhood vaccinations, so they may not be aware of what they've received and what they haven't received. And then need for prophylaxis. So the resources that I alluded to, the CDC website is a great free website you can go to. There are other websites like Travax, which you actually have to pay for a subscription, but I think the CDC website is a great resource, and you can look up by regions, by countries, and they'll give detailed information not only for healthcare providers, but also for your patients to refer to in terms of precautions. So you can look at the CDC website and go to Eritrea. You can find out where that is exactly if you don't know where Eritrea is, which is in Eastern Africa above Ethiopia. And then look at the particular regions that the patient might be going to and what kind of precautions that person should take. So in terms of pre-travel vaccines, we think about hepatitis A, hepatitis B. Hopefully a lot of our patients have been immunized to these or may have had past exposure. Typhoid and yellow fever, I'll talk about a little bit more. And then also meningococcal, which I think is not on everyone's radar, although there was a new Annals paper, which some of you may have seen, specifically looking at meningococcal disease in HIV-infected individuals that I'll talk about. The reason I bring up meningococcus is because there is a meningitis belt in Africa that people don't always think about when traveling as a travel vaccine, but it actually should be considered for a travel vaccine. And in one particular country, it's actually required for entry during meningitis season. So in that country is Saudi Arabia. You actually have to show documentation that you've received the vaccine to enter for a pilgrimage to the Hajj, for instance. So the meningitis belt here, it's actually not all times of the year, but essentially from December to June, you should be considering giving meningococcal vaccine for travelers to that area. And as you can see, there is that overlap to Ethiopia, Eritrea area. There's that little bit that extends there. So you might want to consider that for this patient. in terms of her, she's Hep A and B immune because you've already immunized her for hepatitis B, and she was already immune to hepatitis A by past infection. She's not yet received a typhoid vaccine. Should you give her the live or the inactivated typhoid vaccine? And like before, I kind of want to see a show of hands, if possible, for people who have immunized patients who are going to areas where there is typhoid. Would you use a live or inactivated? So for live, if you want to raise your hands. Okay, so some of you for live, and how about inactivated? Okay, so it's pretty much split about what you would do. Okay, so actually it's interesting. The guidelines are pretty safe in terms of what they want to recommend. And essentially for live vaccines, the guidelines don't really come out and say use them for immunocompromised patients, except for a few that we do have some good data, like I mentioned 2 weeks ago, for instance, like varicella vaccine. But because of the paucity of data for live typhoid vaccine in immunocompromised HIV positive patients, the inactivated vaccine is preferred and is what is recommended. And again, like I mentioned, it's a low level of evidence that leads to this recommendation. So in general, we do give the inactivated vaccine in HIV positive individuals. She's not received a yellow fever vaccine. So for patients who are particularly going to sub-Saharan Africa and but other areas in Africa as well, yellow fever vaccine is required in some of these countries for entry. So we should give her this vaccine. How many of you would give her yellow fever vaccine? If you could raise your hand. Just a couple. How many would not give it? So it actually is, the newer guidelines actually say that it's okay to consider if CD4 count greater than 200, but really considering the risks and benefits. And again, this woman's CD4 count is 450. And the reason why you want to consider the risks and benefits, it's a live vaccine, and there are vaccine-related complications. So there are reports of disease associated with the vaccine where you can actually amplify the vaccine strain of the virus in patients that either get viscerotropic disease or neurotropic disease from the yellow fever vaccine. So it's not a totally benign vaccine. Even in immunocompetent individuals, it can cause problems. So in immunocompromised individuals, we're even more concerned. The CDC previously had recommended even checking for titers to see if there had an appropriate antibody response. And that is, if you're going to an area, for instance, where on the CDC website there is a yellow fever outbreak, if you're going to give the vaccine, you want to make sure that it's protective. And you might want to counsel your patients, maybe this is not a good time to go if there's a yellow fever outbreak and you're immunocompromised from HIV. So again, that's what the whole nuance is behind the risks and benefits. For patients who require a letter for entry or who require the vaccine for entry, you can, as a medical provider, write a note saying that the vaccine is contraindicated so that they can show if they need to show it. And you don't have to put anything about HIV or disclose that. You can just say that the vaccine is contraindicated for medical reasons, and that should be sufficient. The reason why some countries do require it upon entry is because they don't want you to import it from other countries where it's endemic. So if you're coming from the U.S. and not traveling within Africa, it's less of a concern than if your patient is going to multiple countries in Africa. So you discuss malaria prophylaxis with her, and the patient declines as she states that, well, she was born and raised in Eritrea, and she never took prophylaxis for malaria in the 30 years that she lived there. So why should she take a medicine when she goes back and visits family now? None of her family are on it. So what do you do in this situation? Do you convince her otherwise? Mm-hmm. Or do you say, yeah, that sounds reasonable? You, of course, try to convince her otherwise. And she reluctantly agrees to take malaria prophylaxis. And your options for malaria prophylaxis are the following: chloroquine, mefloquine, doxycycline, or atovaquone proguanil. So how many of you for chloroquine? Good. Nobody raised their hand. How about mefloquine? A couple of you raising your hands. How about doxycycline? Okay, more of you raising your hand. How about atovaquone proguanil? Okay, it's all over the place. That's good. So we can talk about what's the best option for this patient. as nobody raised their hands for chloroquine, which is great because, as we know, most of Africa, there is chloroquine resistance. So we wouldn't want to recommend that for prophylaxis. Mefloquine, it's very interesting. There are some drug interaction issues that come up with mefloquine and the protease inhibitors. So ritonavir, actually, there have been some reports that ritonavir increases mefloquine levels by 30%. And for anyone who has taken mefloquine, that's not great because it has a lot of CNS potential side effects similar to efavirenz. And so not great for your patients to potentially get psychotic or have a lot of mood disturbances while they're abroad with their family. And then there's also this question of whether mefloquine can decrease ritonavir levels by 30%, making your regimen potentially not as effective. So both ways it seems to be a potential drug interaction. So mefloquine may not be the best choice for prophylaxis. The other issue, the atovaquone proguanil, which is a great from a side effect profile for patients. For those of you who've taken it for travel, it has none of those CNS side effects. It's generally well tolerated. But atazanavir actually decreases atovaquone by 40%, and proguanil is decreased by 40% as well. So it may not be effective, even though they're taking it and not have a lot of side effects. The PIs may be making it a not effective prophylaxis for them to take. So as some of you indicated, doxycycline is really the go-to drug when someone is on a PI-based, particularly atazanavir, ritonavir-based regimen. And the precaution with the doxycycline is, of course, the photosensitivity with doxycycline. And most of the people that are traveling that need malaria prophylaxis are going somewhere where it's sunnier than in Seattle. So other travel tips that you should talk to patients about with HIV, as you would with any traveler really, is food and water safety, particularly for people with very low CD4 counts, even more so. Insect avoidance, whether that be with mosquito netting, DEET, to use a DEET for avoiding any mosquito bites. In general, outdoor safety, trauma, and when you're abroad in rural areas is not great, and so you want to just caution them about general safety. Animal avoidance, particularly if they're in rural areas for rabies, and there are a lot of stray dogs or stray animals, thinking about rabies in particular. And if they are going to be in a place where they may have a lot of animal exposure, you may want to consider rabies prophylaxis with a vaccine ahead of time. In general hygiene, and then medical care abroad, making sure that they have a good supply of HIV medication. Some people think, well, I could probably get these meds there. They may not have the same regimen. They may not know the exact doses they need to take. Not just their HIV medications, but also any other medications that they may be on. They want to make sure they have an adequate supply. A lot of our patients who travel back to Africa don't just go for a month because it's very expensive to travel and they want to maximize their visit. So they'll go for a couple of months, and there are insurance issues that come up with filling their medications. And so planning way in advance is what you should tell patients who are thinking about going abroad, so they can either stockpile their medications by doing early refills for a couple of months in advance, so they get 6-7 days of early refills, and so they'll have that week supply each month that's extra that they can save, or they have to write a letter, or the provider has to write a letter to the insurance company to ask for an exception so that they can get an extended supply of medication. So again, planning in advance. So for a post-travel visit, let's say she returns from her 4-week trip and she presents to clinic with a 3-day history of chills, fever, headache 1 week after returning home. She has a fever to 38.9, she's tachycardic, hypertensive, but really nothing focal on exam. So fever in a returning traveler, similarly to someone without HIV, the differential should be somewhat similar, even if they do have HIV. So we want to ask about any potential exposures. Again, she may not have done what she thought she was going to do on her trip, so you want to ask about what kind of detour she might have taken in her travel. Did she actually take her prophylaxis? And this comes up because people don't really want to take it when they get abroad because she was sort of reluctant to believe in it anyway that she needed it, and this definitely happens. I just had a patient return from West Africa with malaria because he just didn't take his doxycycline. He didn't think he really needed it. So do ask about that. So differential diagnosis, definitely on the top of the list. You should think malaria, even if you prescribe the prophylaxis and were diligent about that. Even if they said they were taking it, you should still consider it. Dengue, chikungunya, which is similar clinically to dengue and more common in Asia, Southeast Asia, and the Indian Ocean. Typhoid, particularly in the Indian subcontinent, but any of these other areas as well. And then, other more common infections. Could this person just have pneumonia or other types of infections that we see? She actually does have malaria. She has P. falciparum. And so what do you do for this woman? So I mentioned that there are some drug interactions with some of the malaria drugs, and I think that's the main thing that I wanted to emphasize here. Malaria rates are higher in HIV-infected individuals. There are definitely reports of that. Risk of higher levels of parasitemia, particularly with lower CD4 counts, has been noted in people with HIV, and increased risk for severe malaria, meaning CNS, again, higher levels of parasitemia, renal problems with malaria. Treatment is the same, but with the caveat of the drug-drug interactions. And actually, there's a really nice table in the OI guidelines that outlines all the drug-drug interactions that you should be aware of. And again, the issue with atovaquone comes up again. And then the OI prevention guidelines actually recommend avoidance of travel to malaria endemic areas if your CD4 counts are low. However, I have not cautioned people to not go back if they want to see family, and you'll probably have a tough time arguing your patient out of it as well. Again, the prevention should include chemoprophylaxis and personal protective measures, and the treatment, again, is outlined in the OI guidelines. Key points. Pre-travel, talk to them about vaccines, learn about the destination and what precautions your patient needs to take, counseling about safety while they're away, and then post-travel, screen for symptoms and possible exposures.